So yeah, my name is Cathy Duggan. I'm Health Information Programme Lead, and I'm working with the Health Information and Quality Authority, which is known as HIQA. So I'll try not to cover a lot of the same things that Neil has, but just you'll be hearing a lot of different terms in relation to health information, and I just wanted to give you a little bit of clarity around some of them. So the secondary uses of health information. So the primary use of health information is when health information is collected in order to provide care to you. So you go to your GP and he's using that information when providing you with care. And then there's the secondary uses. So this is when information is collected when you're receiving care, but then it's used for other purposes. So Neil mentioned some of the purposes, and I've just kind of grouped a few of them here. So some of them are service planning. So that might just give the information that we need in relation to how many doctors or nurses would be needed in a hospital. In terms of public health, I'm sure everybody's tired of hearing about the COVID numbers on the news every night, but these numbers are really, really important so that the government can make decisions about how to keep us safe. Quality improvement. So health information is used by healthcare professionals to help them to understand which treatments work best and to ensure that people receive the highest possible quality of care. And then research. So researchers can use health information to carry out health-related research, and we hear an awful lot about the work that's being done at the moment to develop vaccines for COVID. So moving on then, so when it comes to secondary uses of health information, or any use of health information, it's really, really important that we find the balance between people's privacy and confidentiality and the need to share data in order to improve healthcare. So in relation to privacy and confidentiality, the risk here really would be if a person's information is used inappropriately or in any way that might make them feel uncomfortable. And then the risk on the other side would be that if we don't use health information for these secondary purposes, then we won't be able to manage the health system, improve healthcare services, and develop treatments to improve care. So really, it's very difficult to strike this balance, but it's something that we have to continue to strive to do. It's the ultimate goal to find the right balance between protecting people's privacy, but also using the data to its full potential. So one of the questions I was asked to answer, which is again a difficult one, is who owns health information? So people generally feel the data belongs to me, it's about me, so it's my data. But often you'll find that healthcare professionals feel that, well, I collected it, I store it, they're in control of it, so they consider it their data. And I think the reality of the situation in Ireland is probably just that it's a little bit more complicated than that. Neil touched on there that patients have rights in relation to their health information. So patients have rights to access, as well as deleting their information, patients have rights to access their own information. But in Ireland, it's currently very difficult to access your own health information. If you wanted to get it, you may need to contact all of the different healthcare professionals that you had seen. You may be able to get some information, but it's quite difficult to get a full picture. So legally, we have a right under the Freedom of Information Act to access our own information. So what you need to do is you fill out a form and then you send in the form to whichever organisation, the GP or the hospital, and then they'll send you your information. But they tend to send you all of the information. And it's been written by healthcare professionals using medical jargon for their own purposes and not with the patient in mind. So it can be very difficult to understand. You might get test results, but there's nobody to explain them to you. So currently in Ireland, just to say, it is quite difficult to access your own health information. That's why things like patient portals, as Neil mentioned, would be really great, and it would be a real step forward. So I'm just going to propose that instead of thinking about ownership, it might be more meaningful to talk about the different roles that people have in relation to data. So I'm just going to use the example of Mary, and actually I saw that Mary featured in Neil's slides as well, the same image. So Mary's in hospital for a procedure on her leg. So she is the data subject. So that means she is the person that all the information is about. So that includes the information that's collected about her. So her personal details, like her name and address, and then also medical information such as test results and medications that she might be on. Mary's in Cork University Hospital, so in CUH, and in this case, CUH is the data controller. So the data controller means the person or organisation who has responsibility for the data. So they make decisions about how the data is collected, used and stored, And it's not just a hospital, a GP or other healthcare provider can also be a data controller. And in this example, CUH, they use a mail delivery service to send a copy of Mary's scans to her GP. So the mail delivery service in this case is the data processor. So the mail delivery service, they're responsible for moving the data from one location to the other or for processing the data. But ultimately, CUH, the data controller, are still in charge of that data and they have responsibility to make sure that it's done correctly. So just coming back to how does access to health information work in Ireland? So as Neil mentioned, we have a mix of paper and electronic records. Ireland is moving towards a more electronic health system, but we're currently quite behind in that regard. And there's still a lot of paper being used. In terms of legislation, so you've heard of GDPR. I think everybody has heard of it at this stage. People are quite sick of hearing about it. So health information is governed by GDPR. And then the Irish Data Protection Acts were also updated in 2018 as a result of GDPR. So the introduction of GDPR really has brought about some positive changes, but there's also some negative changes. So in terms of positive, I think people are a lot more aware of their rights in relation to their data, and they're a lot more aware of what's happening to their data since the introduction of GDPR. Some of the more negative impacts would be that what we have found through my work in HICWA is that a lot of healthcare professionals are actually much less willing to share information since the introduction of GDPR, mostly due to a misunderstanding of it and a fear of sanctions. So they're less likely to share information for direct care with other healthcare professionals and also for secondary uses. So there's definitely a need maybe for some guidance around how GDPR should be implemented in the health system, so that people will have a better understanding so that health information can be shared safely. And then just thinking about some of the secondary uses that I mentioned earlier in terms of legislation. So for research, in 2018, health research regulations were introduced. And that governs the use of health information for research and when you should get consent, and all of the other uses in relation to research. So we do have legislation there. In terms of public health, there's the infectious disease regulations, very strong legislation there, and that's updated whenever there's a new infectious disease, such as COVID. So that's very strong legislation. And then it is an issue that we have here in Ireland is that there's no specific legislation in place for some of the secondary uses. So things like service planning and quality improvement, there's no specific legislation in place for those. And in fact, there's no specific health information legislation for the direct care of a patient either. So there is a bit of a gap in terms of health information legislation in Ireland. So just looking at how other countries do it. So in HICWA, we conducted an international review and we looked at the models that were used in other countries. So we looked at 7 other countries. And all of those countries were much more advanced in terms of electronic health records. So there was a lot of lessons to be learned from them about what works, what doesn't work. All of the countries had legislation in place specifically for health information. And then this was also in places backed up by frameworks or codes of practice that really explained to healthcare professionals how information should be used. And it made it very, very clear. And again, that's just something that we're missing here in Ireland. For some of the uses, there is clarity, but for others, there isn't, and that just means that things aren't being done in a consistent way. Even though we have to comply with GDPR, other countries also have health information specific legislation so that it makes it really clear how the information should be used. Another key finding then from this international review that we did was that ongoing engagement and consultation with patients and the public is the key to success in this area. So many countries, all of the countries that we spoke to indicated that it's really important to engage with patients and the public around their health information. And then in a couple of countries, we saw that they had failed attempts to introduce some of these electronic technologies due to lack of public engagement. So one example is in Australia, where in 2010, they introduced an electronic health record and they introduced it as an opt-in. So you had to opt in to have an electronic health record, and only 10% of people opted in. So it never really took off. And then they reintroduced it in 2016 as an opt-out model. So everybody was opted in unless they chose to opt out. And when we spoke to them, it was around 10% had opted out or even less. So that had actually worked out quite well. And in the UK, in 2014, they had launched a large database called care.data. And again, they failed to engage fully with the public. So what they did was they sent out leaflets to every house in the country, but people thought it was junk mail, so they threw it in the bin. And then they were really shocked a few months down the line to hear how their data was being used. It caused uproar. The whole database had to be scrapped. So they lost millions, and they really eroded the public trust in relation to health information. Okay. So then I've just 2 quick slides. I'll fly through them. In relation to work that HICWA have done in partnership with the Department of Health and the HSE. So in October to December 2020, we conducted a national telephone survey. This was to ask the public about their views and opinions in relation to all the different uses of their health information. And then we also conducted 14 focus groups, so with the public, with patients, with 16 to 18-year-olds, and with some special interest groups. So people who use mental health, sexual health services, people with a disability, homeless, addiction, migrants and asylum seekers, and travellers. And those people were just considered groups that had more sensitive information that might be less likely to want to share that type of information. So I think I've run out of time now, but thank you very much.
Okay, that's great. Listen, thank you very much for that, Cathy.